What percentage of patients, let's put a button on this. What percentage of patients get diagnosed after becoming symptomatic? And let's, for the sake of argument, say symptomatic is a fracture.
So I'll tell you what we do at our institution, and anybody that does FLS or fracture liaison service care does the same. And we did this because it wasn't being done. So between 2008 and now, we've looked at 4 separate analyses. We want to be 100%. So we see someone in the hospital, we invite them to come back. Surprisingly, we only see 1 of the 2 patients, 1 out of every 2. We only see 50% because patients choose to go back to their primary care doctor, or they choose that because of a distance from us. We treat 75 to 80% of the patients who do not have a contraindication post-fracture. That's good, but what else have we learned? Even under our care, we lose them to follow-up, and the typical blueprint in the medical record is maybe a pre-authorization, they're discussing cost, and it's gone. Okay. Or you just see canceled, no show. So the focus for post-fracture care and secondary fracture prevention is because it's not being done. And it's not because no one necessarily wants to do it, it just tends to get lost in we talked about comorbidities. I mean, patients are going back and they have 3 or 4 other problems. The bone problem tends to get lost, and we don't get this done.
Nationally, on a good day,
yep,
at best, you're talking about 30 to 40% of people following a fracture getting diagnosed or treated. And it depends on what plan you look at, whether it's an HMO or not. But that's probably on the high side. So
that's crazy.
Of course it is.
That's just crazy.
Absolutely.
Given your druthers, at what age would you test everybody?
Well, our guidelines is that every woman over the age of 65.
Okay. What about family history? Does that impact it?
It does.
How so?
Well, the docs can tell you the specifics on how a family history would be.
Yeah. The big thing is a parent who had a hip fracture before the age of 80. That's really, but if I know that there are other fractures, or if I know in that family a parent's being treated for osteoporosis and there are other risks, let's say type 2 diabetes, let's say someone smokes, someone has rheumatoid arthritis, that adds to the risk. And essentially, to get the discussion in front of the patient, between the doc and the patient, you need some data and you need something. And again, a bone density test coupled with all of that is the best way to make that initial decision. And if everything's really good, that's not the patient we're going to be doing a DEX every 2 years. It's only the patients at risk where we're close to intervening with medicine, or we're intervening and we're using that to determine their response to treatment.
You mentioned something I want to follow up on, because we did mention blood tests. Oh, it's a cavalier question. What blood tests?
Well, for somebody who has had a fracture, somebody who is at risk, or for whom you diagnose osteoporosis, there's certain basic blood tests that should be done. They're not diagnostic tests. They're part of a secondary evaluation to make sure that there is not something else going on that could be treated. Things like a complete blood count, a comprehensive metabolic panel that includes a calcium, looking for disorders of calcium metabolism, kidney function and liver function, 24-hour urine calcium, and a vitamin D level. There are bone turnover markers, right, which indicate they're an indirect measure of either bone breakdown, bone resorption, or bone formation. And sometimes those can be helpful because they're sort of an independent indicator or risk factor in addition to bone density. But if you think it's difficult to get bone density tests paid for, bone turnover markers are a whole nother aspect.
You know, I sit at this table a lot, and this is a conversation that comes up over and over and over again. And the third-party payers always say, there's only so much money, and I can't spend our money on this. And we had somebody challenge them once and say, it's not your money, it's the patient's money. They still didn't get it, I don't think. But for a disease this prevalent, with this much morbidity and comorbidity, it seems really sad that we're not getting this paid for the way it should be. After all, your disease is the most important disease.
No, but I think for those of us who see patients and see the consequences, what you just said is absolutely true. It is sad. To take somebody who is at a time in their life where they want to enjoy things and all of a sudden can't pick up their grandkids, can't get in the car and drive, can't be out on the golf course, can't travel, can't do the things that give life meaning. We've done a number of surveys with our online sort of population through the National Osteoporosis Foundation, and what patients and caregivers worry the most about, it's not dying, nobody wants to die, but what they worry the most about is losing independence and losing mobility. And we should be doing something to try to prevent that.